joining me today. My name is Dr. Adrian Boudrum at Western University, London Health Sciences Centre. And today I'm going to talk to you about optimizing diagnostic performance for neural antibody testing for autoimmune encephalitis. So I'm just going to go right into it. So in terms of disclosures, I have no personal disclosures, but I will be discussing Autoimmune assays that are research use only in the US and in use here at London Health Sciences Centre Clinical Immunology Laboratory. You might notice that patient information is a bit vague, and that's intentional to protect patient privacy. So in terms of the objectives of my talk today, I'm going to briefly introduce autoimmune encephalitis with an emphasis on the importance of neural antibody testing. I'm going to review the rationale behind panel-based neural antibody testing. I'm going to discuss strategies to optimize testing for paraneoplastic antibodies, GAD65 antibodies, and antibodies against extracellular cell surface or synaptic targets. And I'm going to go over illustrative cases to highlight key testing considerations along the way. So very briefly, what is autoimmune encephalitis? Autoimmune encephalitis is a neuroinflammatory disease of the brain. Its prevalence is comparable to that of infectious encephalitis, the classical form of encephalitis. Its presentation is usually subacute, so less than 3 months. Typical features are that of altered mental status, memory deficits, or seizures. And it may or may not be associated with underlying cancer. When it is, we call that paraneoplastic. These are diagnostic criteria proposed in 2016 for possible autoimmune encephalitis, and it just highlights a lot of the features that I mentioned: subacute onset, memory problems, altered mental status, as well as laboratory or other ancillary test evidence of neuroinflammation. So why does making the diagnosis matter? Well, it's critical for a number of things. It's important for rapid institution or escalation of immunotherapy because these are treatable conditions. It can help guide or intensify malignancy screening when appropriate. It can refine disease prognostication. And it can lead, importantly, to avoidance of other extensive or unnecessary testing. So what types of neural antibodies can we test for? Well, in our laboratory, comprehensive panel-based neural antibody testing for autoimmune encephalitis includes brain tissue indirect immunofluorescence, or TIF, as well as paraneoplastic antibody testing for the antibodies you see there, with Autoimmune line blot corroborated with TIF when applicable, GAD65 antibody testing by ELISA, as well as Autoimmune line blot corroborated with TIF, and cell surface synaptic antibody testing, including the ones you see there, by Autoimmune cell-based assays, and again, corroborated with TIF. So what we're going to do is we're going to review these assays for detection of paraneoplastic, GAD65, and cell surface synaptic antibodies, and we're going to focus our attention on strategies to optimize test performance, as well as the importance of clinical serological correlation, or correlating the test results with the patient presentation. I'm going to sound like a broken record because I'm going to say that a lot throughout this talk. And throughout, I'm going to also provide some illustrative case examples to try and highlight a few key points. So diving right into it, first up is paraneoplastic antibodies. So paraneoplastic antibodies are antibodies that have been discovered that have a high, over 70% association with cancer, as well as with paraneoplastic neurologic syndromes. Examples include anti-HU, RE, YO, CV2 or CRIMP5, amphophysin, MA2, TR, and ZIC4. And for these antibodies, detection by 2 assays is recommended to ensure high clinical specificity, such as by line blot and brain tissue indirect immunofluorescence. Commercial kits to test for paraneoplastic antibodies are available. Both line blot and brain tissue substrate are sold as separate kits. However, there has been some interest in using line blot as a standalone assay due to ease of implementation and interpretation compared to interpreting brain tissue staining patterns. However, very importantly, the positive predictive value of line blot alone has been shown to be suboptimal in clinical practice, between about 30 to 50%. That means that over half or more than half of the time, you may encounter a false positive if you use this assay alone. And Autoimmune has highlighted that there are various line blots in addition to indirect immunofluorescence tests, and results should only be used for diagnosis when both test results are congruent and are in line with the clinical symptoms. Which is very important. So that is to say, line blot should be performed alongside a confirmatory test, such as brain tissue indirect immunofluorescence, as highlighted by Autoimmune. So a few examples of this. First up, we have an older woman with subacute cerebellar ataxia. She has an underlying malignancy found on comprehensive screening, and she had an autoimmune encephalitis panel ordered. So what we see here is that the line blot was 3+ positive, strongly positive for anti-Yo antibodies. Brain tissue indirect immunofluorescence shows staining compatible with anti-Yo. I've shown you there on the right what this looks like. So you see very prominent staining of the cytoplasm of the Purkinje cells, and there's also staining of the myenteric plexus there shown in the top and bottom panels respectively. And this is diagnostic of paraneoplastic cerebellar degeneration with a true positive anti-Yo result. In this case, we have positivity confirmed by 2 assays and also a compatible clinical phenotype. The vast majority of patients with anti-Yo have cerebellar ataxia. Now, as a contrasting example, the next patient here is a middle-aged woman with chronic, over 30-year history of temporal lobe epilepsy. Her seizure history was very stable up until a psychological traumatic event about 5 years ago, with the increased spells thereafterward. No malignancy was found, and she had an autoimmune encephalitis panel ordered for refractory temporal lobe epilepsy. Now, her line blot was 3+ positive, strongly positive for anti-Yo. However, brain tissue indirect immunofluorescence shows no neural staining, as I've shown there on the right. We don't see any Purkinje cell staining or myenteric plexus staining. And in this case, the diagnosis was idiopathic temporal lobe epilepsy with a false positive anti-Yo line blot result. And this illustrates a few key points, which is the importance of positivity by 2 assays, as well as corroborating the test result with the patient presentation, because chronic temporal lobe epilepsy is not a typical phenotype for this antibody. So there's a few take-home points. Paraneoplastic antibodies are very helpful biomarkers of both paraneoplastic neurologic syndromes and underlying cancer. And whenever possible, positive results should be confirmed by 2 assays, such as line blot and tissue indirect immunofluorescence, to minimize false positive results. There's a few special considerations to keep in mind. For anti-SOX1, the role of brain tissue indirect immunofluorescence remains to be better defined with variable sensitivity recorded across assays. And for anti-recoverin and anti-titin, which are also included on the line blot, these do not reliably stain brain tissue, and confirmatory tests are not routinely available in clinical practice. So for these antibodies, correlating a positive line blot result with the clinical presentation is particularly important to gauge clinical relevance, as they have discrete clinical associations, such as that of anti-recoverin with autoimmune retinopathy and anti-titin with thymoma or myasthenia gravis. And in general, again, clinical serological correlation is essential to corroborate suspected true and false positive results. So moving right along to GAD65 antibodies next. So high levels of anti-GAD65 associate with core GAD65 disease manifestations. These include stiff person spectrum disorders, cerebellar ataxia, temporal lobe epilepsy, and limbic encephalitis. In contrast, low levels of anti-GAD65 are nonspecific and can be found in patients with diverse neurologic syndromes. So in terms of what high levels means, assays to determine high levels have historically included brain tissue, so staining on brain tissue, as well as radioimmunoassay using published cutoffs. Values above them have been considered to be high levels. Anti-GAD65 ELISA is also available, and recently ELISA cutoffs have also been published that can guide what is considered a high level of this antibody. Anti-GAD65 line blot is also available through Euroimmune and detects high levels of anti-GAD65, although false positives may rarely occur. Corroboration of a positive GAD65 line blot with another assay, such as radioimmunoassay or ELISA, can be helpful to confirm high levels of anti-GAD65. And confirming these high levels is particularly important in patients who do not have a typical disease phenotype. So I'm going to go through a few examples of this. Example 1. Is a middle-aged woman with subacute cerebellar ataxia, so a typical phenotype of GAD65 neurological autoimmunity, cerebellar ataxia. Comprehensive cancer screening was negative, which is not uncommon with GAD65 antibodies, and an autoimmune encephalitis panel was ordered. What we see here is that the line blot is 3+ positive, strongly positive for anti-GAD65. Anti-GAD65 ELISA is well over 10,000, about 625,000 international units per ml. Brain tissue indirect immunofluorescence is shown on the right there, and you see very typical staining of the hippocampus, thalamus, and granular layer more so than molecular layer of the cerebellum, which is very typical for GAD65 antibodies. And then for reference, you'll see the kidney there is negative. There's no non-neural staining noted. So the diagnosis in this case is GAD65 cerebellar ataxia with a true positive anti-GAD65 result. And we know that this is a true positive because we have positivity by multiple assays that have demonstrated high levels and a compatible clinical phenotype. Moving on to a contrasting example, example 2. So this is an older man with progressive cognitive difficulties, gait disturbance, and urinary incontinence. Worth noting that his cognitive difficulties were not the typical amnestic difficulties of limbic encephalitis, but rather more of a dysexecutive syndrome. His gait disturbance was not that of ataxia, but more of a magnetic type gait, and he had urinary incontinence, as I mentioned. So this is not a typical phenotype for GAD65. Brain MRI showed findings concerning for hydrocephalus, interestingly, and he did have an autoimmune encephalitis panel ordered. So what we see here is that the line blot is again 3+ positive, strongly positive for anti-GAD65. However, by ELISA, we have a negative result, less than 5 international units per ml. And brain tissue indirect immunofluorescence, shown on the right there, interestingly shows staining, but it's non-neural specific staining. So we see staining of not just the brain, but also the gut and the kidney, and no typical staining of GAD65. And overall, the patient's diagnosis was most compatible with normal pressure hydrocephalus with a false positive anti-GAD65 result. So a few take-home points here. High levels of anti-GAD65 associate with core disease manifestations. These include stiff person spectrum disorders, cerebellar ataxia, epilepsy, and limbic encephalitis. Corroboration across assays, such as line blot, ELISA, tissue indirect immunofluorescence, can be helpful to confirm high levels of anti-GAD65, particularly in patients with atypical phenotypes. Important to remember that high levels of GAD65 antibodies are necessary but not sufficient to diagnose GAD65 neurological autoimmunity, and therefore it's always important to correlate a high value with the patient's clinical presentation. So moving right along to cell surface synaptic antibodies. So these refer to antibodies that bind extracellular cell surface or synaptic targets and include NMDA receptor antibodies, LGI1, Caspr2, GABA B receptor, AMPA receptor, and DPPX antibodies, among numerous others. And neural antibody positivity by 2 assays for these antibodies, such as cell-based assay and tissue indirect immunofluorescence, has the highest specificity. Now, cell-based assays may have higher sensitivity than tissue indirect immunofluorescence for certain antibodies, but this can come at some cost to specificity with the possibility for false positives, particularly if only weak serum staining is observed by cell-based assays, such as for anti-Caspr2 or NMDA receptor cell-based assays. And in case you're wondering what weak serum staining refers to, I've showed here on the left typical staining for anti-NMDA receptor antibodies by cell-based assay. There's a small arrow there pointing to a typical staining of a cell process from the cell there on the left. In the middle, you'll see a similar staining pattern, but with only weak immunofluorescence. This is weak positive serum staining. And on the right, you have negative staining. No staining is seen. So the middle panel there is an example of weak serum staining for anti-NMDR by cell-based assay. So in terms of interpreting these assays, experience with reading them can help identify true positives because that will give you familiarity with typical versus atypical staining patterns. For anti-NMDAR, testing CSF can support a true positive result. This is because CSF has higher sensitivity and specificity than serum for this antibody. For anti-Caspr2, serum is more sensitive than CSF, but so we can't rely on a negative CSF result to rule out a weak positive serum result. But testing serum at a higher dilution, such as 1 in 100 rather than 1 in 10, which is the standard dilution for serum cell-based assays by Autoimmune, can help to support a true positive result. So I'm going to give it a few examples to highlight these points. So I'm going to start off here with an older man who presents with increasing temporal lobe seizures over 3 months. He also has new onset memory difficulties and blood pressure lability. So a subacute multifocal neurologic presentation. A serum autoimmune encephalitis panel was ordered. And what we see here is a positive anti-Casper2 cell-based assay, clear positivity at the 1 in 10 dilution. And also on brain tissue indirect immunofluorescence, we see very typical staining of the hippocampus, thalamus, and molecular and granular layers of the cerebellum. So we have positivity by 2 assays. We have a very compatible clinical phenotype, and the ultimate diagnosis here was anti-Casper2 encephalitis with a true positive anti-Casper2 result. Now, as a contrasting example, example 2, this is an older man who presents with indolent cognitive decline over 6 years. So again, less typical for neuroinflammatory disease to prevent very indolently over multiple years. Brain MRI showed no features to suggest limbic encephalitis, but did show striking, symmetric white matter changes. And his mother, interestingly, passed away from quote-unquote dementia with white matter changes many years ago. He had a serum autoimmune encephalitis panel ordered for progressive dementing illness. And what you'll see on the far left there is weak positivity for anti-Casper2 by cell-based assay at 1 in 10 dilution. When we retest his serum at 1 in 100 on the following panel there, there's no staining seen. So this is a negative serum cell-based assay for anti-Casper2 at 1 in 100 dilution. And his brain tissue indirect immunofluorescence is also negative. So in this case, we have positivity by cell-based assay just at the 1 in 10 dilution, but not at the 1 in 100 dilution for this patient's serum. And only positivity by 1 assay is seen. And ultimately, the patient has a more likely diagnosis of genetic leukodystrophy. And this is an example of a false positive anti-Casper2 result at the 1 in 10 dilution. So a few take-home points for these antibodies. Positivity by 2 assays, such as cell-based assay and brain tissue indirect immunofluorescence, has the highest clinical specificity. Whenever you see weak positivity for serum cell-based assays, this requires further evaluation. For some antibodies, such as anti-NMDAR, this may be CSF evaluation that's most helpful. For other antibodies, such as anti-Casper2, testing serum at a higher dilution may be helpful. And in general, clinical serological correlation is essential to corroborate suspected true positive and false positive results, because you can use the clinical phenotype to help inform the likelihood of a relevant result by determining whether a patient has a presentation that fits with that antibody or not. So moving right along here, I'm going to discuss a little bit about expanded neural antibody testing. So numerous other neural antibodies, in addition to the ones that I've talked about so far, have been discovered in recent years that can aid in patient diagnosis and treatment. So these are antibodies that have high clinical relevance. However, they're often not included in commercial panels, but they can be comprehensively screened for by brain tissue indirect immunofluorescence or other tissue-based assays. Examples include anti-AGLON5, mGluR5, GABA-A receptor antibodies, and numerous others. So I'm just going to go over a few examples of what I mean by this. So starting off with the first example here. So the first example is an older man with rapid neurologic decline and progressive respiratory failure. Extensive serologic testing was non-diagnostic, and an autoimmune encephalitis panel was ordered. And so what we see here on brain tissue indirect immunofluorescence is clear staining of the hippocampus, the thalamus, the cerebellum, molecular layer and granular layer, the glomeruli of the kidney, which I've highlighted with arrows there, as well as the smooth muscle. And so when we see this staining, this typical brain staining, glomeruli staining, and smooth muscle staining, this is all very suspicious of AGLON5 antibodies. And this was confirmed by Autoimmune AGLON5 cell-based assay, which I've shown here on the right. And this patient's diagnosis was ultimately anti-Aglon 5 neurological autoimmunity with prominent bulbar dysfunction and unfortunately respiratory failure. Moving on to another example here. So this is a middle-aged man with cognitive decline and seizures. Extensive serologic testing, again, for this man was otherwise non-diagnostic. And an autoimmune encephalitis panel was ordered. So what we see here on brain tissue indirect immunofluorescence is very prominent staining of the hippocampus. It stands out in contrast to the thalamus. And the cerebellum shows very minimal, if any, staining. So this is very much a hippocampus predominant staining pattern. And this is very typical of anti-mGluR5. And this was confirmed by a Euroimmune mGluR5 cell-based assay, as I've shown on the right there. And this patient's diagnosis was ultimately mGluR5 encephalitis, and this antibody has an association with Hodgkin's lymphoma, which was ultimately found in this patient as well. So a few take-home points about expanded neural antibody testing. Neural antibody discovery is advancing at a rapid pace. It seems every year there's 1 to 2 newly discovered neural antibodies. Panel-based testing that includes brain tissue substrates, such as brain tissue indirect immunofluorescence, is a comprehensive and cost-effective way to screen for these antibodies, many of which are discovered or first identified using tissue-based assays. It's also more cost-effective than increasingly large panels of cell-based assays, for example. In patients that have a suspicious tissue staining pattern on brain tissue indirect immunofluorescence, a second assay, such as a cell-based assay, can be performed as a reflex test to confirm neural antibody positivity, as I've demonstrated in these last 2 cases. So as a few conclusions, neural antibody testing is an increasingly useful biomarker in patients with suspected autoimmune encephalitis. Panel-based testing that incorporates a brain tissue substrate allows for maximal sensitivity, specificity, and cost-effectiveness. Strategies available to optimize testing for paraneoplastic GAT65 and cell surface antibodies are available. And if you're not sure about these testing strategies, whether they're in place or not at your laboratory when you receive a test result, particularly in a patient with an atypical phenotype, I recommend that you contact your testing laboratory, because open communication between the ordering physician and the laboratorian can be extremely helpful in those cases. And once again, correlation of the test result with the clinical presentation is essential when interpreting neural antibody results, as this can help confirm true positivity when everything lines up, both the test result and the patient's presentation, and also can flag potential false positive results if you receive an antibody result that seems incongruent with the patient's presentation. So these are just several of my references throughout the talk. And many thanks to all of the very hardworking individuals in the London Health Sciences Center, Clinical Immunology Laboratory, our biochemist, Dr. Yang, Dr. Bayana, our manager, Vili, many of the MLTs that work there as well. It's an excellent effort by everyone there, as well as thanks to Euroimmune for hosting this event. And if you have any questions or would like to reach out, please don't hesitate to email me or call my office anytime. Thank you so much for listening.